Today we have invited people from our UHS and our partners in the community to share their work in reducing disparities in our community and the patients that we serve. I have a couple of housekeeping announcements before we get started. There is a list of scheduled presenters and the times, and Dr. Leung will have the lovely job of keeping us on time. So presenters, please know that he will give you a 1-minute warning and maybe otherwise to kind of keep us on track because we have a packed schedule of great stuff. If you're interested in attending our RUHS implicit bias training, it will occur from 3 to 4 today. There is a different link, and if you haven't already registered, we'd love for you to do so. And again, that will be dropped in the chat, so please find time to do that. That should be another great training that will come our way today. This session is going to be recorded and will be available after. So again, we welcome you as we share and we learn together. Our first speaker today is going to be Jennifer Cruikshank, our leader here at our UHS, and we'd like her to kick off our webinar. Thank you, Jen.
Good afternoon, everyone. Welcome to today's conference. I want to first start by thanking our DEI task force and our two chairs, Dr. Kumar and Dr. Leung, for bringing us all together. It is such an important conversation at a very important time. I'm going to say things you all already know far better than I do, but this COVID pandemic has certainly brought to light the health disparities and structural inequities that have existed in our society for years. The pandemic certainly highlighted measurable differences in outcomes across our populations in our very own communities. And now a lot of people at many levels across society are actually talking about healthy places indexes, pointing to zip codes and talking about serious disparities. This is something that you all have known for a long time, and you have all dedicated many, many hours and many years of your lives to helping to resolve in our own system. It's really exciting to see the community and the whole world talking about this. 3 words alone, diversity, equity, and inclusion carry an enormous responsibility for every single one of us. And within our systems of service delivery, we have a lot of work ahead. Work to ensure that every member in our team understands their own unconscious biases and really embraces their role to connect each person to the right service. But more importantly, that we all develop a structure of service that is truly accessible and useful for every single person in every community. As a healthcare provider, I tend to focus on just simply health equity to start. And what's health equity? And you all know this far better than I. The CDC definition sort of simply puts it, health equity is achieved when every person has the opportunity to achieve his or her own potential, and no one is disadvantaged from achieving that potential because of their social position or other socially determined circumstances. Health inequity happens whenever one of us cannot access the system that allows us to live up to our potential. And we all know that happens every moment of every single day for some of the people in our population. As a safety net provider, our UHS has always focused to identify and address specific disparities. And we have demonstrated really positive impacts when our patients actually connect with our system. However, we know and understand that there are many people in our communities that still lack healthcare coverage. So they're not connecting to services that they seriously need. We also understand that we have an entire population of patients assigned to us, and we do not connect with all 100% of them. And that is of grave concern for us. We know that our system is structured in a way that might not be accessible to all of them. We work rigorously to improve access to care for our patients and address those health equities, but we also know we have a very long way to go, a lot of learning to do, and certainly a lot of listening to do as well. So timely access to trusted services and resources where everyone, regardless of race, place, or circumstance, is an important part of what we need to provide. Every person must know how to access these services. Every person can access those services when they need them. It actually makes sense to them. And services where the people know where they go and where we meet them, where the patients are, where the people are, is super important to our UHS and our entire team. So I look forward to hearing about innovative ideas around how we improve access to service, address health inequities, better understand unconscious bias, and taking action on building structures and services to better support every single person in our community, regardless of their social position or socially determined circumstances. As a society, we have everyone's attention. The urgency certainly exists, and we all feel the commitment from so very many people across the country. I know you are here because you care and you want to make a difference, and thank you for that commitment. I know we can only do this all because we're doing this together, so thank you very much for joining us today.
And we appreciate that. Dr. Terwenka, our Chief Medical Officer, will share a few reflections with us now.
Thank you. So I was asked to say a few reflections from my own experience. And, I need to say that 30 years ago when I joined this organization, I had some other offers in other local hospitals that were much more lucrative. But there were two things that attract me to this place. One was I love the way that education was done here for physicians, but also the diversity in the population. And so we sat down with my wife and decided, hey, it might be a little bit, we may make a little bit less money, but the satisfactions are going to be so much greater. And I have not regretted a minute that decision. And the diversity is seen in multiple different ways. We see ethnical diversity, but also even as or more important, we see socioeconomic diversity. And we see that within one ethnicity, things might be very different depending on the socioeconomic status of that person. But also within a socioeconomic stratus, we see differences on ethnicity within that similar socioeconomic status. And because of my background and having been born and raised in Argentina, of course, I had an inclination about our Hispanic patients that are very important, ethnic composition within our UHS. And immediately in working here, you start seeing the differences, and not now with COVID, but before COVID, and it's going to come back. You see the big family in the room. Sometimes, as a physician, you go to talk in the room, and there are like 10 members of the family, and that might seem strange, or might seem that hey, we might be or might make you a little bit nervous. But when you start understanding, the different, cultural background, you see that if you engage that family, that patient gets so much support from so many members of the family that can be your partners on healing. And they also tend to be extremely appreciative of things when things go, the right way. We had to learn that when we give some delicate news or bad news, or we communicate to someone that maybe they have cancer or other things, we cannot do the same for all patients or for all ethnicities. There might be an ethnicity, and I don't want to use stereotypes here, but just as a example of differences. But there may be an Anglo patient that you say, you have cancer, and the patient, okay, how long do I have? And, I want to know exactly when, it might be, do I need to put my affairs in order? And actually that person might be fighting to prove you wrong, that you said, okay, this is the prognosis. But you go to another, ethnic culture, and if you say like that, that person becomes devastated and might give up and not fight with you for something. So it is so important to understand those differences. And then, of course, we see in this institution pathologies that are rarely seen in other places. Very advanced disease, sadly, and that is many times related to both the ethnic diversity, but the socioeconomic. and patients that feel that they don't have a place to go. And so they don't seek healthcare until it's very late or advanced. So that's why, like Jen Cruikshank was mentioning, that we have been working so hard to increase access within our community, on our community health centers, and also increase access within our specialties. So the referral doesn't need to wait, 4 months to see the specialist, and by that time it might be too late. And we're not there. Still, there is a lot of work that we need to do in relation to access, and also in educating the community. So that's why through our community health centers, through our public health partners, and through some things that we had been doing in the past, and hopefully now that COVID is, better, we can again do in reaching out to churches in the community. And we have worked significantly, especially with the Catholic Church, that have some very large Hispanic churches, where we have gone in the past with our primary care physicians, with our behavioral health, knowing also on some cultural differences, where in some cultures search for behavioral health care seems to be a stigma, and we need to understand that even as clinical physicians, when we're seeing patients that might need behavioral health help, how we can approach that differently. So and then finally on inclusion and diversity. We really want to be a health system that is very friendly to our LGBTQ community. And I'll tell you from personal experience, and I have my own religious background and my own bias because of my religious background in relation to the LGBT community, until one of the close members of my family resulted that that was their inclination. And it's interesting how you think differently, or you start thinking and understanding, where that community goes when you have somebody that is very, very close to you that is undergoing some of that. So that's why, I really like that our system is friendly to that community, is friendly to the transgender community too, that sometimes is not included in many of the things. And then finally, I would like to work to end with two experiences. Now with COVID, we really saw the ethnical differences in the desire to get their vaccines. And we have really worked with some African American churches and groups, and also with some Hispanic groups, to really try to help them understand the importance that the vaccine could have in helping them to at least prevent more serious consequences from COVID. And also we have tried to do the same with another community that I think it is part of the diversity of patients that we take care, that is the inmate community. And I need to tell you that sometimes as clinicians, we're a little bit concerned of taking care of inmates, but it's interesting. I have experience and many times share with my residents some of the greatest satisfactions and appreciation comes from inmates, that if you treat them with kindness, if you treat them with respect, because they're not used to that in general. And the majority of them really appreciate when you treat them like a real human being, with respect, and include them in the decision, and you don't dismiss them because of the situation that they are having, as deserved as that situation might be. So those are a few of my own experiences with different diversities within RUHS. And I'm very proud because I think that we had been doing a lot in different silos. So I'm so grateful that we have this group that is trying to put many of the different things that we're doing on perspective, and is also allowing us to see other areas that we need to grow and increase in supporting diversity and equity and inclusion without the community that we serve. So thank you very much.
Thank you, Dr. Trebrinka. Next, we'd like to invite Janelle Morris, our Chief Operating Officer, for a few updates. Janelle.
Hi, good afternoon, everyone, and thanks for having me out. I really just want to make a brief statement and then I'll do an introduction. Just as biases, inequities, and discrimination can become deeply entrenched in the system, so can diversity, equity, and inclusion. Course correction requires tenacity, insight, and transparency, and we here are on a unique path, and we are uniquely positioned and ethically responsible to continue this journey. We're responsible for ensuring that our patients have access to high quality care, and we must also build an environment where our patients and our providers feel safe and accepted and secure. At this time, I'd like to introduce Abby Totten, Plan President of Molina Healthcare of California. Abby is a healthcare executive with almost 20 years of experience in Medicaid and California managed care. Abby has extensive experience in Medicaid, public policy, and managed care operations. Most recently, before joining Molina, Abby was the medical program officer at HealthNet, where she was responsible for their $7 billion California Medicaid business. She has also worked at California Association of Health Plans and Local Health Plans of California. Abby graduated summa cum laude from the University of Minnesota, earning a Bachelor's of Arts degree in child psychology and English. She lives in Sacramento with her husband and 2 children. This workshop means the world to me, and watching this organization grow and watching our community partners just participate and have deep involvement. So I thank you all for being here, and welcome, Abby.
Thank you, Janelle, and thank you for the opportunity to be here today. So for those of you who don't know me, my whole life has been in Medicaid. All I've ever done from the time I moved out to California and got into the work world was work in the Medicaid space, from healthcare policy into the position I hold now as the plan president for Molina. So this is an issue and a topic area that's really near and dear to my heart. Let's go to the first slide. There we go. So for Molina and for me personally, I believe that equity starts from within. As an organization, as many of you know us, we were actually founded originally as a community clinic in Long Beach over 40 years ago. And the mission of the organization has really remained the same, which is to serve vulnerable and low-income populations across the state. We actually first became a health plan in 1994, which makes you go, oh my gosh, you guys were actually a clinic for a long time before you ever got into health plan space. And so we try, although we're not always successful, to keep that approach at the forefront of what we do every day. We are also exclusively focused on the government-sponsored programs, so you won't see us do commercial coverage. When you hear about us nationally with mergers and acquisitions, we aren't going to buy companies that don't do what we do every day, which is Medicaid. For MHC, for the California market, we have about 440 employees with more than 3,400 of employees across the state of California that serve our company nationally. When I first started here, one of the things I looked at was, who are the people of my team? Who leads our organization, and what does our organization look like from the inside? And what I found so incredible was that, over 83% of our employees are women. And more than 40% identify as Hispanic or Latino, which, given our roots, makes a lot of sense. And overall, over 71% of our employees are non-white. And when I looked back at my leadership team and we started to get to know each other, we realized even at our leadership level, many of the people in our organization
were on Medicaid at some point in their life. And so they continue to be focused and driven to serve the underserved and to make sure that we're accounting for the diversity of our membership, not just in what we do every day, but in who we hire and the practices we have. I think I've got some, if you want to hit forward, it'll pull up some more stats on the slide. One of the things that makes us a little unique, I think you have to hit the arrow. I think there's we had fun with some graphics flying across. There we go. So Molina is actually 83% Medicaid, which kind of gives you a little view of kind of where we stand versus other commercial health plans that serve in the Medicaid space. And as I said, what we really look to do is we actually hire from all the communities we serve. So when you look at the individuals who you as an organization are largely interacting with, our case managers, our nurses, they actually live in the community. We also have extensive training on diversity, equity, inclusion best practices, because we all know we have implicit bias, but how do we ensure that we're removing that implicit bias? It's acknowledging it, it's training, it's talking to each other, it's having open and honest conversations. And then we work to align our processes to make sure that we have culturally appropriate approaches to care, whether it's ensuring that our case managers are fully trained in the populations they served, or ensuring that we have a good distribution of individuals who speak the native languages of the members that they're going to be interacting with. We want to make sure that our people know the population and can interact in ways that are culturally appropriate. Let's go to the next slide. So I wanted to take a little bit, oh, I forgot I had one more. We'll go to the next slide. So for the Inland Empire, we took a little bit of a look at kind of what do we see in the data? What makes the Inland Empire different? And so I had my team pull up our HEDIS scores for 2021. These are unaudited findings, so this isn't where we'll end at the end of the year. It's just our most recent poll. But as you'll see across the measures, there's quite a broad distribution of scoring. So from very far from the 50th to very close, and even some over the 50th percentile nationally. And then we dug in a little bit. So if you click forward, it'll pull up some of the stats we're seeing. So breast cancer screening, if you look at the distribution of scores across any of the different race categories as designated by the state, there is a very different outcome on the HEDIS rates. And the outcomes don't necessarily align with what you would expect based on the literature. So for example, in breast cancer screening, we see actually that our white members fare significantly lower on screening rates than our Hispanic and Latino members. And similarly with cervical cancer screening. So then we have to take a step back and say, okay, what are the interventions we're using, and drill down into each of those populations to understand what drives that disparity. We had a great example in one of our communities where we had learned from one of our community partners that, for example, Afghan women who make up a large percentage of newly enrolled in some of our service areas were not going to get cervical cancer screenings. And so we started asking questions, and actually what we learned was that it was believed that Pap smears were only for married women. And so many women were not going in because it wasn't seen as a cancer screening. And so we worked with the community to actually recreate our cervical cancer screening educational materials. So instead of saying Pap smears, it said cervical cancer screening. And really changing the dynamic on what the community believed was an appropriate service for women in their population. So let's go to the, if you click forward again. Again, this pulls apart our prenatal results. Here we see what we actually have seen very much in the literature, which is Black and African American women fare far worse in prenatal and postpartum care than other individuals across our population. And so we specifically, much like Inland Empire Health Plan, we launched our doula program early in hopes of further improving access to culturally appropriate care. We've also had some really great opportunity and are actually launching for this year a new partnership with an organization that will provide basically peer-to-peer support for African-American moms. It's called Papa's Pals. They will actually be paired with an African-American mom who's in the prenatal phase, and will work with them throughout the course of their pregnancy and through postpartum. I'm actually coming into the home, helping them with daily chores, working on making sure they get to their appointments, even potentially driving and doing things like picking up groceries. It's really a way to try to do education and support in the home by pairing individuals with those who are aligned from a cultural and cultural standpoint. We've also pulled up here some of the stats around our well child visits. Again, it's in some ways it's kind of surprising to see the distribution of scores across the membership, but it really means that we've got to take the time to drill down into what is driving this distribution, and within those populations, is there something about utilization patterns, where they're assigned from a physician standpoint? Are they assigned at the clinic level? Are they going to a individual practice? Are they individuals that were defaulted versus chose to be in the plan? And so we try to really look not only at race and ethnicity, but drilling down even further into the data to determine if there's something else. Maybe it's not just race and ethnicity, maybe it's our assignment process for unengaged members that will help to improve the likelihood that people are getting the right services at the right time. So if we go to the next slide, in looking at our overall approach to closing disparity gaps, we have to all admit that we can't boil the ocean. You got to take things one step at a time, and you have to really be community focused. So the first thing that we really want to do whenever we identify a potential disparity gap is look at our data. What does our data show us? What does it tell us? And really refine and develop our approaches first based on our data. But let's be really honest. Data does not show us everything. And so what we try to do is then take what we've learned from our data, the action plans that we've initially developed, and then bring it to the community. Are we taking the right approach? Is our data telling us the truth, or is there something that we're missing? We had a really incredible opportunity in this last year to the earlier discussion about the LGBTQ plus community to start our own LGBTQ plus advisory group. We've asked organizations from across all of our service areas to join us on a quarterly basis to dig into issues of disparity and equity within the LGBTQ plus community and give us their feedback. What are we missing? And what is it that we as a company have failed to identify? And there were a couple of things that we learned. First and foremost, our educational materials were not looked at from that lens. And so we brought our educational materials to the committee and asked them specifically for feedback, the pictures we used, the language we used, and how we were phrasing our education. We also, and some of you may have received, we did a survey of our network and asked the question, would you be willing to be a Centers of Excellence, be an LGBTQ plus friendly practice, so that if our case managers or our call center get a request, we have somewhere to refer to. It's not necessarily that everyone wants a little asterisk in the provider directory, but if we have members who need services and need help, then we want to be able to do that type of referral. We also have looked at,
Sorry to interrupt, Abby. This is Jeff. to do a time check and let you know that we're at time.
I am almost done, so that makes it easy. And so then lastly, we look at not only what did we learn, but then what can we do next? And so what are the different types of innovations that we can deploy on the ground? And so we've done everything from our practice transformation teams, getting into our individual provider practices. We're actually launching later this year a mobile drop shop to bring care into rural communities as well as as RVs. We've done, telehealth, e-consult, as well as deploying our own nurse practitioners into individuals' homes, and then expanding, as I said, to new partners. There are an incredible number of innovators in this field who are looking to address care differently. And so we really have the opportunity to kind of turn care on its head and find ways to address members' needs in the way that they are most comfortable, that is culturally appropriate for them as well. So I don't know what you guys want to do from a question standpoint, but I'm more than happy to answer any questions. And again, just really appreciate the opportunity to be here today. So there you go.
Thank you very much. Just a quick housekeeping item. If you have any questions, please post them in the chat. We will try to get them to the presenter, as we will not have time for live answers during the session. Thank you.
So our next speaker is Dr. Gabriel Pina, who is one of our pediatric attendings. She's the Director of Quality Improvement and Advocacy for the Primary Care Track of the Loma Linda Pediatrics team, and we're very happy to have her.
Hi, thanks for letting me join this workshop. I'm super excited to be here. I won't take a ton of time. We are doing a lot of things in the realm of diversity and inequity, but our main focus is on improving the diversity in the workplace. And so just a little background knowledge, and some of these slides are adapted from Dr. Chad Versio. So our nursing population, so the population of the Inland Empire is as listed above. You can see the numbers. I don't need to read them because, we're all pretty literate here. And then the nursing population below matches, but doesn't align in the minority populations, including African American and Hispanic, Latinx, American Indian and Alaskan Native, right? So we know that there's a gap in health inequities because there's been multiple studies that show that providers with similar cultural ethnic backgrounds provide better care in some instances for populations that they can identify with. Next slide. This isn't unique just to nursing. This is a visual approximation, a visual representation of what it looks like across California, but it's also true of pharmacy. Next slide. So pharmacy has similar demographics. There's a bit of a drop off with population to pharmacists for Caucasians. There are about 50% drop off for African Americans, and Latinx is almost 75% or more or less than the population matches. So again, it's the same and hasn't really been changing. And the graph below is the URM enrollment for pharmacy schools over the past 10 years. Pretty consistently the same, which means whatever we've implemented in the interim is not seeming to do some long-standing change. And again, this is true of nursing, pharmacy, and our next slide we'll talk about what it looks like for medical students in medicine. So this is a figure from the AAMC, a percentage of accepted U.S. medical students applied by race and ethnicity, and you can see it's overwhelmingly Caucasian. And then the rest of the minorities are very small slices of the pie, which is not a true representation of our community or even the communication of America. And so that's one of the issues that's been noticed in the AAMC and why DEI has been completely a focus of the AAMC over the last decade or so. Next slide. And this is what the figure looks like over the past 40 years for U.S. medical student application by race and ethnicities. And so you can see the top line is Caucasian, so blue, so slightly fluctuant, but overall majority. And then the next most populous line is Asian, followed by the bottom two, the middle two are African American and Hispanic Latino. And then the bottom line is American Indian Alaska Native. So you notice that the last three have not really increased substantially in numbers compared to their counterparts. And the next slide. But what's most stark, I think, is the number of Black males who are graduating from U.S. medical schools and becoming physicians. And so you can see in the beginning, it was a majority of Black males, and now it's majority Black females, with a percentage of African Americans graduating from U.S. medical schools, and the number continues to drop for Black males. And we know that there are a lot of specific health issues in Black male populations that Black males know better. I mean, I can talk to Black families about Black issues, but I cannot talk about what it's like to be raised as a Black male in America right now, or ever. Next slide. So what have we done? So our biggest push is in pathway development. We are, how everyone else tends to know it, is called pipeline programs, but pipeline implies that it has a single trajectory, right? So a pipe only goes to one place or goes to one location. A pathway implies that they can go to many locations in healthcare or outside of healthcare, but right now we're focusing on healthcare, and that includes things like physical therapy, occupational therapy, nursing, psychiatry, psychology, anything that has to do with health. That's what we want minorities to be a part of. And so Dr. Dexter Frederick, who is a graduate of Loma Linda Medical School and did his residency at Loma Linda about 16 years ago, started this program called BEST in Tampa, Florida, called Brain Expansion Classic Training. And it is probably one of the coolest pathway programs I've ever experienced. We were allowed to go to a conference and learn some one-on-one education on how they implemented and founding funding, and how they were able to recruit their programs. And since then, they have developed 5 programs. They have a summer program, an educational program, a social determinants program, which I think is really awesome. So you can evaluate that in a first level when they're experiencing SDOHs. And then also a DOC program where it teaches them how to do study skills and test well, because we know that's a handicap, is the testing ability and success rate or correlations, right? So we learned a lot from him. Next slide. We currently partner with Western with quite a few things. Not only do we take their DO students, but we also love their pathway program. So they have a health career ladder, which it also has a Native American component. So they have Pomona Health Career Ladder and Native American Career Ladder. And they are amazing programs, one Saturday a month for about 7 months, including a graduation. And we are active and involved at almost every session, giving a lecture to either the students and the parents or both. And they've become like a little community for us. And we taught about COVID. We taught through COVID. We did Zoom lectures. We made Christmas packages so everyone could bake pancakes together, and we baked pancakes in our home with them, and it's been such an enriching experience to be a part of them. We also do their summer program, which is called SHPEP. SHPEP is a nationally recognized summer health professional education program at multiple locations that takes freshmen and sophomores interested in healthcare to a university that has a medical school. And they stay for 6 weeks, and we do 2 sessions of lectures for them, as well as fireside chats to get to know them. And that's one of our favorite things. And then the next one is,
we're at our last minute.
Oh, good. It's my last slide, so it works out great. And then the last portion is what we're doing also at Loma Linda. So Loma Linda has a ton of these small pipeline programs or pathway programs, but they're not intermingled, and they do not involve mentoring. So I'm working with this wonderful man, JC Belliard, who's the VP of Community Relations, to connect all the majority of their pathway programs so they make one contiguous pipeline program, so that we can continue to increase the diversity of the workforce for the future of all of us. Thank you.
Great. Thank you so much, Dr. Pina. We really appreciate your time. At this point, we're going to move forward to Luz Gallegos, the Executive Director at TODEC. Luz?
Hello, everyone. Like the compañera said, my name is Luz Gallegos, and I work for TODEC. TODEC is a grassroots community-based organization serving immigrants since 1984. Here in the Inland Empire. We were founded in the city of Paris. Since then, we've grown to be a regional organization serving 4 counties, which is Riverside, San Bernardino, Inyo, and Imperial counties. TODEC is an acronym for Training, Occupational Development, Educating Communities. TODEC was founded as an advocacy organization to organize and advocate for farm workers, specifically here in the city of Paris, where we're founded. Back in the day, a big portion of West Riverside was very rural. We still have a lot of rural, but not as much as we did in the past, where we organized farm workers. As you all know, Paris all the way to the Tijuana border, we are a border region. So what that means is that we are used to seeing Border Patrol patrolling our streets, separating families. So for us, where we organize is very important for us because this is where immigrants live and the hardship is real. We also have an office in the Coachella, which is serves the Coachella Valley all the way up to Blythe. And of course, Coachella is another border region, Coachella all the way to the Mexicali border, which same scenario where we have a lot of our farm worker communities. And then of course we have our San Bernardino County, 2 offices in San Bernardino County. But the TODEC's work is around immigrant issues. TODEC, like I said, we started as an advocacy organization to protect and elevate the realities of farm workers and immigrants, not only dealing with labor, but also with immigration. Back in the day when the farmers didn't want to pay our workers, they would just call Border Patrol because they were already in our community, and they would call them and deport them. A lot has changed since. A lot of rights that we, in a collaboration across the state and across the nation, we passed a lot of laws that continue to protect and defend our immigrant communities. As we see, our most vulnerable communities are undocumented immigrants that don't have privilege and don't have access to safety net programs like healthcare, like Medi-Cal coverage. Well, thanks to a lot of work that we have been doing at TODEC, in the 80s, one of the biggest ones we had was the amnesty that helped over 3 million immigrants, especially farm workers, gain a legal residency. So that's how we became a service provider, because TODEC started as an advocacy community organizing organization to organize immigrants and farm workers, but we had to fill in the gaps that we had here in the IE. We passed this law, and now it was up to us to help these thousands of immigrants that lived in our region to file their legal paperwork. So we had to become a service provider. That's how our legal services started in the 80s in the implementation of the amnesty. A lot of folks know it as La Amnistía, that was signed by President Ronald Reagan, but at the end of the day, it was a community effort. Since then, organization continues to organize but advocate for and elevate the realities of immigrants, farm workers here in the state and in our region. Fast forward, we continue to provide all these services, but as it relates, TODEC, we do provide free immigration legal services for those immigrants that meet the criteria, that meet the guidelines. And it's only here in the state of California where we are able to provide free legal services for California residents because of the funding that we receive. A lot of the services that we offer deal with any aspect within immigration law. Right now, we also have a fund available for immigrants that are trying to naturalize and become citizens. We have a fund that if they qualify under our criteria, where TODEC is able to pay USCIS the fee for an immigrant to become a naturalized citizen. So we have that fund. We also have another fund to help youth or young adults that are protected under DACA, which is Deferred Action for Childhood Arrivals, not only to provide them with the free legal, but we also have a fund to pay off their fees for immigration. So we have different types of support that we were able to gain through a lot of elevating the realities of our immigrants community and the need to continue supporting. As you all know, the pandemic has opened a lot of eyes and continued to shed light in the equities that have existed for many, many decades. And through the work that we do at the grassroots level, we see this firsthand. I myself, at one point, I thought I was undocumented because my parents were undocumented. When we would hear La Migra, I would run just like they did. And my parents were farm workers, and I remember hiding, within the fields when we would hear, "Here comes La Migra." So for me as a person, and as an organizer, it's very personal, the work that we do in the organization. That's why when the pandemic hit our region, right away we started organizing and elevating the realities to our governor's office and to our legislators that they needed to do more, especially for immigrants that fear even going to the doctor, even seeking any type of benefit because they're scared that they might lose the possibility of in the future getting a green card. And this came about from the last Trump administration that did a lot of changes to what's known public charge and the way immigrants see public charge in their eyes, that if they get any type of benefit, that they would put themselves at risk. And if there's any type of law that would come down the pipeline, it would impede them from getting a green card. So with that said, we saw a lot of the challenges that our community was having and the fear for them to even seek healthcare. So right away, we started collaborating with public health here in both counties and also in the state of California, but to be in the community to help we mobilized over 311 of our youth that stepped up to the game to make sure that we were protecting our families. And since then, we haven't stopped, but bringing a lot of resources to the immigrant community, particularly those that are undocumented, and also farm workers. Through advocacy, we were able to convince the governor to prioritize ag workers in the state of California. And we are very proud, and we should all be proud, everybody that's on this call, because we live in Riverside County and the amazing teams that we have here. As through our advocacy convinced the governor's office, but then again, he put out that it was up to every county to prioritize as they saw fit, because every county has different populations. So advocacy here with working with public health and also working with our supervisors, we were the first county in the whole United States that starts vaccinating farm workers. But a lot of that work came way before we started vaccinating in January, because at the same time, TODEC was organizing and also educating community, because we were already hearing the myths that community was hearing. So we began really early in mid 2020 to start debunking a lot of the myths, but also to start organizing farm workers and prepare them. We were telling them, we're organizing, we're putting pressure on the governor to prioritize you, but we want to make sure that you're going to be ready when the vaccines are ready for you in January, because we knew we were going to win. And thank God, we got that through, and we were able to work with public health and the growers as well to bring vaccination to our fields. And our workers were ready, because we had already started this work way before. So for us, it's been a privilege to really work in collaboration with public health and all the different systems, because as we continue to advocate, I don't know if, I'm pretty sure you all know, but if you don't know, it's important for all of you to know. Through advocacy, we were able also to expand Medi-Cal coverage for undocumented immigrants 50 years and over. So as of May 1st, implementation started, and we were been working with the County of Riverside with the DPSS office to also bring this information to our workers and for them to actually seek Medi-Cal, because for us, it took a lot of work to advocate for a lot of the bills that we were able to win, but the implementation is where it's at. We want to make sure that every single Californian, especially in our region that we serve in the Inland Empire, that's able to qualify for any of these benefits, do so, because it's about saving lives. So that's some of the work that we do, but we're very thankful, and we're here to help in any capacity. We provide education and outreach. We have over 60 topics that intersect with immigrants here in the IE. So if you ever need us, utilize us as a resource, because all our staff is ready to help. And thank you again for the opportunity to come and share some of our work.
Thank you, Luz. As our next speaker, we have Dr. Marty Baum, who's a pediatrician. She serves as the medical director for community benefits at Loma, and also as the medical director for community engagement at the SAC healthcare system.
Thank you very much. I'm really pleased to be able to talk about something that is, I think, hits all of our hearts, and that is we look at social determinants of health and how that's impacting the health that we provide to our own patients. It's kind of the beginning of how do you talk about the marrying and the connection between community and clinics, or community and healthcare. So this is how we originally started out. I have a short number of slides to show one project that we did in Children's Hospital. But before we started there, we looked at, what is our opportunity for really engaging with social determinants of health in our workflow adoption. And so as you start on the left-hand side, or the far side with the lighter colored circles, you will see that this is where it actually is really at the patient level. And as you go across the slide to the right-hand side where the darker slides are, you'll see that that's where you start getting information that has to do with population, has to do with your population of health, has to do with your community, it has to do with your analytics. And we call this care share. And we thought this was a great opportunity to start to talk about how care is really shared between communities, and it's shared with us in the clinical realm. So on the top side is actually where you had the contact with the patient, and the bottom part is the process. So we started in with mission, realizing that whatever we could use electronically would be helpful to actually gather this information from patients, whether it was at MyChart or sign in, and we use the social risk factors. And then this would move on into the social work team within 24 to 48 hours of workflow, and this would begin the resourcing of families. And this is to avoid the bias that often social workers say happens. They don't get necessarily a consult from the family because there is not a sense that the family actually needs resources or a social work team. So there's a bias that everybody is okay that might look okay. And so we know in healthcare, and we know working with population, that that is not necessarily true. Then that moved on to the medical team, which was responsible for coding, putting it in the chart documentation, making it available so Care Everywhere would be able to see this. Once that's all done, then you move on to the ability to be able to have an analytical team, and you could start looking at risk stratification for families, integration into the chart, readmission rates. And then that in and of itself moves out of our medical realm and into regional informatics. And then you're starting to looking at, well, community needs assessment. We started understanding our communities better, and this is obviously something that can lead into community benefits reporting, which is required. Next slide, please. So what we did is we did a pilot at Loma University Children's Hospital. We did this in the middle of COVID. These are the leads that we had. There was myself and Carlson and Dr. Cabina, and we had resource leads from Ron Stewart, who is head of our Help Me Grow Inland Empire, which serves as a repository for any patient that can call in from 0 to 8 years of age on the website to be able to get social resources. And then, of course, our lead, Myra Benitez. We had interns who worked with our questionnaires, and our senior residents and our social workers team that rounded out our team. So next slide. This was done between August and September. What our workflow was, we took 100 sequential patients that were admitted to Loma Linda University Children's Hospital, 0 to 18. We had one team that we decided we would try and understand the workflow with one team. This was a paper form that we started with, and this was completed in the first 24 hours by an intern. This was the social risk factor that is embedded in EPIC. This was then taken back to the social work team, and the patients were divided into 2 categories. They were considered high risk if they had a CPS report in the past, if they had had an admission to the hospital within 6 months, if they were a CCS or a California Children's Service patient, which is higher complexity, and if they had suicide ideation. Low risk was sent over to Help Me Grow, and that was a referral that was sent to them. Then it went back by communication to the team. Resources were provided to the family, and our lessons learned is that social determinants of health screening is not in the regular wheelhouse of physicians. So next slide. So this is a response that we had from families. We had 2 patients that were unable to complete the questionnaire because the child was taken to the surgical team and moved to a different team. 2 patients unable to complete the questionnaire because they went to the behavioral medicine center. 1 patient, the parent was not available during the regular hours during the day. 1 parent stated it would be better when the mother arrives, so she knows how to answer these questions, which we thought was interesting. And then anecdotally, the parents' overwhelming response was very positive, saying nobody has ever asked me if I needed help. And we went back through the charts to see if under standard questions that were done on an H&P for going into the hospital, if they would have gleaned any of the responses, and the answer was no. So we realized that this was our opportunity to address bias that we have and to elevate this to a threshold response, which means all patients screened. Next slide. So this is the results. We only did 6 domains, and as all of you know, with social determinant wheel on the left-hand side, which is part of the EPIC social risk factor questionnaire that comes in Foundation EPIC. And you can see that after our first 24 to 48, we had a threshold. We were saying within 24 to 48 hours, these children need to be screened. And I want you to look at the gray box because it was astounding. It was more concerning than I even thought we were going to see. And that is food insecurity was almost 40% or 2 out of 5 patients. Financial risk at about 38%. Transportation about 10%, and then your stress level at 37%. We included 2 wellness parts of the wheel, which was physical activity and isolation, because we know that those can be very important when you're looking at stress reduction. How is it you can keep the families active, and how is it that you can keep them engaged with their community? We know that COVID caused an extreme amount of isolation, which also leads into stress. So this was our lessons learned, and one of them was the importance of universal, or what we would call threshold screening, which means every patient, our goal would be to get every patient that walks across our threshold is screened so that we do not have a sense of bias. And then we also started early, so it's not right prior to discharge that you realize that the family that's going home has a huge transportation issue, and they're actually dealing with issues of food insecurity. So the icons are really shown at the left-hand side, which I think are really helpful in looking at the domains. We chose just six domains to get started. So again, next slide. So what this taught us is, so this is what we use as our 9 critical steps for success for patients. And this is the outpatient workflow of what we're looking at with social determinants of health. And as you look at the first 3 steps, you can realize those are really heavy in the IT part. And that is that it must be electronic, must be available through MyChart or Welcome Tablet or at my bedside. And the questionnaire, of course, has to be electronic, has to be deployed early. And then also as physicians, we tend to not see stuff even in the Epic chart. So we figured, let's just place this connection of social determinants of health all over the chart so that you almost have to trip over yourself to not be able to see it. So we placed it in Snapshot. It is in the wellness wheel, can be viewed on Storybook. You can see this in maintenance. And then we move into where we start to consider the physician realm, which is it can be pulled into the notes by a BPA. There's a trigger that says we would suggest you would consider using an ICD-10 diagnosis, a Z code of which we can prioritize based on the ones that we're seeing from CalAIM and from IEHP. And then we need to be able to drop the CPT code, which is this is for a behavioral health questionnaire. Then we get to the place of, okay, now how do we make a difference for these families? How do we really create a connection for family for resources? So we've proposed that there is a care hub, and that is where referrals can be sent. And this is a care hub. We use Help Me Grow at the Children's Hospital, which covers children from 0 to 8. It can be any clinics can have a care hub, which would mean a single person in the clinic would be helpful in helping to make sure that patients are connected to referrals, whether they use Connect.IE or whether they use a different process, whether they put something in the AVS. Some clinics, and then the issue is that you could have that maybe all of internal medicine had one care hub and all of the information goes to that one particular desk where that person looks to connect patients. Then when we start to move into 8 and 9, now we're starting to look at closing that loop, or the holy grail, which means the patient actually got there and received services. There's a letter that goes back, meets our quality metrics, and then we move on to analytics and a dashboard. So next slide and final slide is this is what we're doing next. This starts in 2 weeks. We've gone to this is the same workflow. We've moved into an electronic form. We have 2 versions that we're using of the risk factor. This again will be completed now electronically by MyChart or tablet workflow of social work team. We've not changed the sort, but we have allowed the social work team to have a wild card if they have a sense that a family is more in trouble. We've added an SDOH table for discrete drop-down data to be followed. Several automations have been allowed for pulling in SDOH into the notes. There's referrals for Help Me Grow, and there's suggestions for Z code. We use secure chat, and then at the very end, we are looking at MyChart, discharge, carrying those resources forward. I think our lessons learned is that social determinant screening is still not in the wheelhouse of physicians. but we hope to increase that as we move forward with additional studies. So thank you very much.
Thank you, Dr. Baum. And our next speaker is Renita Lewis, who's the regional manager with the Department of Public and Social Services.
Good afternoon, everyone. As mentioned, my name is Renita Lewis. I'm a regional manager with DPSS Children's Services. A lot of you know it as Child Protective Services, and so excited to be here today. You know, our national organization for social work has a theme every year, and the theme this year is "The Time Is Now." And I can't speak highly enough about DEI efforts and RDD, racial disproportionality and disparity efforts, really hitting home as far as the time is now. And it's almost as if there's a call of action. And so I currently chair our collaborative, our RDD collaborative within our organization. And I just want to give you a couple of strategies that we're working on, but I wanted to give you some demographics of our organization. Some of you might not be familiar. We are reintroducing ourselves to our community as champions for families and children. And we're investing in children and families and communities, bringing problem solving, collaboration, emotional awareness to every case. Our goal is to strengthen families, starting by ensuring their physical, mental, and emotional safety for all children. Our practices and partnerships center around the safety, stability, and well-being of children. We are, and this was a key for us, we are listening to our families and communities so everyone in our care feels honored and safe. Next slide, please. So in regards to reports that come into our organization, our Division for Child Abuse and Neglect, we have about 6,800 children who, then this is for 2021 as of last year. We had 6,800 children that came in for case management care. We actually opened a case and served them. However, we received 63,475 calls our child abuse and neglect hotline. Of those calls, 30,128 referrals resulted in were referrals that resulted from those phone calls. 22,242 were actually completed investigations. About 80% of all of our referrals come from mandated reporters. Some of the examples of mandated reporters are schools, law enforcement, medical providers, and therapists. Next slide. When children come into our care and they are actually removed from their family, from their parents or guardians, they're placed in an alternate living arrangement. And this is the breakout of the types of placements that they may be involved with. 44% are resource family homes, and those are relatives or family non-related familiar members, non-relatives, but they are familiar with the children. They make up about 44% of all of our placements. 40% are actually placed in foster family agencies or foster homes, and those are non-relatives. And then we break it down even a little bit further. We had 4% that were in our short-term residential therapeutic program, and that's our group homes. And then our SIPs are they're more flexible type of placements where our older youth are able to, like a dorm or renting a room somewhere. It's more of a transitional type of placement. And then we had 200 children last year that found their forever family. Next slide. So this is the meat and potatoes of the work that we're doing in Riverside County child welfare. This chart gives you an ethnicity and path through the child welfare system. So it's an ethnic an ethnic breakdown of each ethnicity as they go through each decision point of our organization. So it's broken out by all of the ethnicities, and then every single path that each child goes through within our organization. So the first pillar is actually the child population for Riverside County. And if we look at it, you see that 0.5% are Native American. This is the child population as of 2021. And for Asian Pacific Islanders, the child population is 5.4%. For our Latino population, they make up the majority of the child population in our county, 59.5%, almost 60%. And for our white children, they make up about 28.8%. And our African American or our Black children make up about 5.8%. And what caught our attention is that as we go through the different decision points within our organization, whether we're looking at what the mandated reporters are calling in as allegations, we look at our investigations, we look at our substantiations, what we actually determine is true. We look at our entries, that these are children that come in our system. We look at in care, these are children that go into foster care, and then we look at exits, who's been in our system for long periods of time. We can see that there's disproportionality and disparity amongst our African American population. If you look at the first pillar and the fifth pillar, the black child is represented in the child population at 5.8%. However, that percentage in care is almost 3 times more. And it's 3 times more than our Latino children and our white children. So that caught our attention and brought us to the table. This has been something that's been occurring for several years. And our administration and all of our leaders in our organization is really committed to moving this pendulum from the place that we're at over to the place we want to be. And this is requiring that we bring up some awareness within our organization. So we started with our leadership. We actually contracted and brought in people to come in and talk with us about implicit bias. And it started with our leadership, with our managers, and it's already starting to trickle down into our regions as the managers transfer that learning onto their own teams. Next slide. And some of the other areas, this says building and maintaining safety. And this was like our mantra of how we provided a lot of our services. But our lens has changed, our focus changed. Now, after we looked at the slide that preceded this, and we saw that we have an overrepresentation of Black children within our system. And we've got to do some drastic changes to address that. And we needed to look at some of the services that we were providing, and are they tailored to children and families of color? And so this is the next stage after we move further along in our building awareness within our own teams. We're looking at our service providers and some of the things that our families are involved in and are engaged in. And as we move further, it's really been a community effort. And so that's another goal that we have, to even engage further with our community and involving them in this process as we go along. Thank you.
Thank you so much, Renita. We've come to the end of our first hour, and what a great first hour that was.